This is just a little brief overview of some things that you can do to maximize your management of urinary incontinence to optimize productivity in an office setting. So the patient comes in. They say, I want you to stop my leaking, and they don't really have a clue about why they leak, when they leak, how much. So we've sort of gone through some of this stuff on the male side, but what you need to figure out is how much they leak, how bothersome is the leakage, and it's the usual stuff. But in order to be optimized, you want to try to do that a lot earlier. So my goal when I see this patient for the first time is I've agreed that I have enough information to know whether they're a stress, urge, overflow, or mixed type incontinence, and then I've gotten rid of some of the things like nocturnal polyuria, etc. So until everyone is in agreement about the why, no treatment plan is likely to be effective. So if a patient has mixed incontinence, we're going to spend some time trying to discuss whether their problem is more of an urge problem, more of a stress problem. And as Ryan said earlier with the rule of thirds, the thing I tell everybody is if you've got both, it's likely that if I treat your stress incontinence, your urge might get better, but it might get worse. And so we do have to have an agreement on what the biggest issue or problem is. So our basic evaluation. Focus history, including duration, severity, previous medical therapies, previous surgery, and an emphasis on the obstetrical history. Culture and cytology have indicated, voiding diary, and I've sort of given up on pad weight, but I am kind of interested in at least a pad count. And we do try to get questionnaires that these can be sent out ahead of time. And so one of the things that we do try to do, we look at this as being sort of a team approach. And so the first thing we try to do is have one of your mid-levels, whether it's a PA or an NP, can do all of this before your visit. This